Pain is a complex, unpleasant sensory and emotional experience associated with actual or potential tissue damage. It's a subjective feeling that varies from person to person, even with the same injury or condition. Pain can be a crucial signal, alerting the body to potential harm, but it can also be a persistent, debilitating problem. Subjective experience: pain is not just a physical sensation, it also involves emotional and psychological components. Warning signal: pain can alert us to injuries, illnesses, or other problems that need attention. Personalized: the way each person experiences pain can be different, even with the same underlying cause. Varied sensations: pain can manifest as sharp, dull, burning, tingling, or aching sensations. Can be acute or chronic. Acute pain is short-term and usually resolves with treatment or healing, while chronic pain lasts for a longer duration. Why is pain important? Protection: pain helps us avoid further injury by making us aware of harmful situations. Diagnosis: pain can be a key indicator of underlying medical conditions. Motivation: pain can motivate us to seek treatment and improve our health. Managing pain. Multifaceted approach: pain management may involve medication, physical therapy, psychological support, and other therapies. Personalized treatment: what works for one person may not work for another, so finding the right approach is essential. Importance of communication: open communication with healthcare professionals is crucial for effective pain management. In essence, pain is a multifaceted experience that plays a vital role in our well-being. Understanding its nature, causes, and management is crucial for both preventing injury and promoting overall health. Pain is a distressing feeling often caused by intense or damaging stimuli. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with, or resembling that associated with, actual or potential tissue damage. Pain motivates organisms to withdraw from damaging situations, to protect a damaged body part while it heals, and to avoid similar experiences in the future. Congenital insensitivity to pain may result in reduced life expectancy. Most pain resolves once the noxious stimulus is removed and the body has healed, but it may persist despite removal of the stimulus and apparent healing of the body. Sometimes pain arises in the absence of any detectable stimulus, damage, or disease. Pain is the most common reason for physician consultation in most developed countries. It is a major symptom in many medical conditions, and can interfere with a person's quality of life and general functioning. People in pain experience impaired concentration, working memory, mental flexibility, problem-solving and information processing speed, and are more likely to experience irritability, depression, and anxiety. Simple pain medications are useful in 20% to 70% of cases. Psychological factors such as social support, cognitive behavioral therapy, excitement, or distraction can affect pain's intensity or unpleasantness. In many cases, pain fits into one or a combination of three categories. Nociceptive pain, caused by inflamed or damaged tissue that activates pain sensors called nociceptors. Nociceptive pain is divided into superficial and deep pain. Deep pains are divided into two parts, deep physical and deep visceral pain. Neuropathic pain, caused by damage or malfunction of the nervous system. Neuropathic pain is divided into peripheral, the source being the peripheral nervous system, and central, being from brain and spinal cord. Peripheral neuropathy is often described as burning, tingling, electrical, stabbing, or pins and needles. Nociplastic pain is pain that arises despite no clear evidence of tissue or somatosensory system damage causing the pain. In 1994, the International Association for the Study of Pain recommended using specific features to describe a patient's pain. Region of the body involved, example abdomen or lower limbs. System whose dysfunction may be causing the pain, example nervous or gastrointestinal systems. Duration and pattern of occurrence. Intensity. Cause. Pain is usually transitory, lasting only until the noxious stimulus is removed or the underlying damage or pathology has healed. But some painful conditions, such as rheumatoid arthritis, peripheral neuropathy, cancer, and idiopathic pain, may persist for years. Pain that lasts a long time is called chronic or persistent, and pain that resolves quickly is called acute. Traditionally, the distinction between acute and chronic pain has relied upon an arbitrary interval of time between onset and resolution, the two most commonly used markers being 3 months and 6 months since the onset of pain, though some theorists and researchers have placed the transition from acute to chronic pain at 12 months. Others apply acute to pain that lasts less than 30 days, chronic to pain of at least 6 months duration, and subacute to pain that lasts from 1 to 6 months. A popular alternative definition of chronic pain, involving no arbitrarily fixed duration, is pain that extends beyond the expected period of healing. Chronic pain may be classified as cancer-related or benign. Allodynia is pain experienced in response to an ordinarily painless stimulus. It has no biological function and is classified by characteristics of the stimuli as cold, heat, touch, pressure or a pinprick. Phantom pain is pain felt in a part of the body that has been amputated or from which the brain no longer receives signals. It is a type of neuropathic pain. The prevalence of phantom pain in upper limb amputees is nearly 82%, and in lower limb amputees is 54%. One study found that 8 days after amputation, 72% of patients had phantom limb pain, and 6 months later, 67% reported it. Some amputees experience continuous pain that varies in intensity or quality, others experience several bouts of pain per day, or it may reoccur less often. It is often described as shooting, crushing, burning, or cramping. If the pain is continuous for an extended period, parts of the intact body may become sensitized, so touching them evokes pain in the phantom limb. Phantom limb pain may accompany urination or defecation. Local anesthetic injections into the nerves or sensitive areas of the stump may relieve pain for days, weeks, or sometimes permanently, despite the drug wearing off in a matter of hours, and small injections of hypertonic saline into the soft tissue between vertebrae produces local pain that radiates into the phantom limb for 10 minutes or so and may be followed by hours, weeks, or even longer of partial or total relief from phantom pain. Vigorous vibration or electrical stimulation of the stump, or current from electrodes surgically implanted onto the spinal cord, all produce relief in some patients. Mirror box therapy produces the illusion of movement and touch in a phantom limb, which in turn may cause a reduction in pain. Paraplegia, the loss of sensation and voluntary motor control after serious spinal cord damage, may be accompanied by girdle pain at the level of the spinal cord damage, visceral pain evoked by a filling bladder or bowel, or, in 5 to 10% of people with paraplegia, phantom body pain in areas of complete sensory loss. This phantom body pain is initially described as burning or tingling but may evolve into severe crushing or pinching pain or the sensation of fire running down the legs or of a knife twisting in the flesh. Onset may or may not occur immediately years after the disabling injury. Surgical treatment rarely provides lasting relief. Breakthrough. Breakthrough pain is transitory pain that comes on suddenly and is not alleviated by the patient's regular pain management. It is common in cancer patients who often have background pain that is generally well controlled by medications but who also sometimes experience bouts of severe pain that, from time to time, breaks through the medication. The characteristics of breakthrough cancer pain vary from person to person and according to the cause. Management of breakthrough pain can entail intensive use of opioids, including fentanyl. Asymbolia and insensitivity. A patient and doctor discuss congenital insensitivity to pain. The ability to experience pain is essential for protection from injury and recognition of the presence of injury. Episodic analgesia may occur under special circumstances, such as in the excitement of sport or war. A soldier on the battlefield may feel no pain for many hours from a traumatic amputation or other severe injury. Although unpleasantness is an essential part of the IASP definition of pain, it is possible in some patients to induce a state known as pain asymbolia, described as intense pain devoid of unpleasantness, with morphine injection or psychosurgery. Such patients report pain but are not bothered by it, they recognize the sensation of pain but suffer little or not at all. Indifference to pain can also rarely be present from birth. These people have normal nerves on medical investigations, and find pain unpleasant, but do not avoid repetition of the pain stimulus. Insensitivity to pain may also result from abnormalities in the nervous system. This is usually the result of acquired damage to the nerves, such as spinal cord injury, diabetes mellitus, diabetic neuropathy, or leprosy in countries where that disease is prevalent. These individuals are at risk of tissue damage and infection due to undiscovered injuries. People with diabetes-related nerve damage, for instance, sustain poorly healing foot ulcers as a result of decreased sensation. A much smaller number of people are insensitive to pain due to an inborn abnormality of the nervous system, known as congenital insensitivity to pain. Children with this condition incur carelessly repeated damage to their tongues, eyes, joints, skin, and muscles. Some die before adulthood, and others have a reduced life expectancy. Most people with congenital insensitivity to pain have one of 5 hereditary sensory and autonomic neuropathies, which includes familial dysautonomia and congenital insensitivity to pain with anhidrosis. These conditions feature decreased sensitivity to pain together with other neurological abnormalities, particularly of the autonomic nervous system. A very rare syndrome with isolated congenital insensitivity to pain has been linked with mutations in the SCN9A gene, which codes for a sodium channel, NaV1.7, necessary in conducting pain nerve stimuli. Functional effects. Experimental subjects challenged by acute pain and patients in chronic pain experience impairments in attention control, working memory capacity, mental flexibility, problem solving, and information processing speed. Pain is also associated with increased depression, anxiety, fear, and anger. If I have matters right, the consequences of pain will include direct physical distress, unemployment, financial difficulties, marital disharmony, and difficulties in concentration and attention. Harold Mirsky 2000. On subsequent negative emotion. Although pain is considered to be aversive and unpleasant and is therefore usually avoided, a meta-analysis which summarized and evaluated numerous studies from various psychological disciplines, found a reduction in negative affect. Across studies, participants that were subjected to acute physical pain in the laboratory subsequently reported feeling better than those in non-painful control conditions, a finding which was also reflected in physiological parameters. A potential mechanism to explain this effect is provided by the opponent process theory. Pain can be treated through a variety of methods. The most appropriate method depends upon the situation. Management of chronic pain can be difficult and may require the coordinated efforts of a pain management team, which typically includes medical practitioners, clinical pharmacists, clinical psychologists, physiotherapists, occupational therapists, physician assistants, and nurse practitioners. Inadequate treatment of pain is widespread throughout surgical wards, intensive care units, and accident and emergency departments, in general practice, in the management of all forms of chronic pain including cancer pain, and in end-of-life care. This neglect extends to all ages, from newborns to medically frail elderly. In the U.S., African and Hispanic Americans are more likely than others to suffer unnecessarily while in the care of a physician, and women's pain is more likely to be undertreated than men's. The International Association for the Study of Pain advocates that the relief of pain should be recognized as a human right, that chronic pain should be considered a disease in its own right, and that pain medicine should have the full status of a medical specialty. It is a specialty only in China and Australia at this time. Elsewhere, pain medicine is a subspecialty under disciplines such as anesthesiology, physiatry, neurology, palliative medicine, and psychiatry. In 2011, Human Rights Watch alerted that tens of millions of people worldwide are still denied access to inexpensive medications for severe pain. Medication. Acute pain is usually managed with medications such as analgesics and anesthetics. Caffeine, when added to pain medications such as ibuprofen, may provide some additional benefit. Ketamine can be used instead of opioids for short-term pain. Pain medications can cause paradoxical side effects, such as opioid-induced hyperalgesia, severe generalized pain caused by long-term opioid use. Sugar, sucrose, when taken by mouth, reduces pain in newborn babies undergoing some medical procedures, a lancing of the heel, venipuncture, and intramuscular injections. Sugar does not remove pain from circumcision, and it is unknown if sugar reduces pain for other procedures. Sugar did not affect pain-related electrical activity in the brains of newborns 1 second after the heel lance procedure. Sweet liquid by mouth moderately reduces the rate and duration of crying caused by immunization injection in children between 1 and 12 months of age. Psychological. Individuals with more social support experience less cancer pain, take less pain medication, report less labor pain, and are less likely to use epidural anesthesia during childbirth, or suffer from chest pain after coronary artery bypass surgery. Suggestion can significantly affect pain intensity. About 35% of people report marked relief after receiving a saline injection they believe to be morphine. This placebo effect is more pronounced in people who are prone to anxiety, and so anxiety reduction may account for some of the effect, but it does not account for all of it. Placebos are more effective for intense pain than mild pain, and they produce progressively weaker effects with repeated administration. It is possible for many with chronic pain to become so absorbed in an activity or entertainment that the pain is no longer felt, or is greatly diminished. A number of meta-analyses have found clinical hypnosis to be effective in controlling pain associated with diagnostic and surgical procedures in both adults and children, as well as pain associated with cancer and childbirth. A 2007 review of 13 studies found evidence for the efficacy of hypnosis in the reduction of chronic pain under some conditions, though the number of patients enrolled in the studies was low, raising issues related to the statistical power to detect group differences, and most lacked credible controls for placebo or expectation. The authors concluded that although the findings provide support for the general applicability of hypnosis in the treatment of chronic pain, considerably more research will be needed to fully determine the effects of hypnosis for different chronic pain conditions. Alternative medicine. An analysis of the 13 highest quality studies of pain treatment with acupuncture, published in January 2009, concluded there was little difference in the effect of real, fake, and no acupuncture. However, more recent reviews have found some benefit. Additionally, there is tentative evidence for a few herbal medicines. For chronic, long-term, lower back pain, spinal manipulation produces tiny, clinically insignificant, short-term improvements in pain and function, compared with sham therapy and other interventions. Spinal manipulation produces the same outcome as other treatments, such as general practitioner care, pain relief drugs, physical therapy, and exercise, for acute, short-term, lower back pain. There has been some interest in the relationship between vitamin D and pain, but the evidence so far from controlled trials for such a relationship, other than in osteomalacia, is inconclusive. The International Association for the Study of Pain, IASP, says that due to a lack of evidence from high-quality research, it does not endorse the general use of cannabinoids to treat pain. Thank you for watching this video.